go proceed to the next talk with the DVT and PE with Dr. Ash Guha. Thank you.
Good morning, everyone. So, you must all be wondering, why are we talking about DVT-PE? Now as more and more interventional tools become available to treat thrombosis, DVT-PE is becoming much of a cardiology realm where a lot of the PERT programs or PE response team programs are coming up across all hospitals, which are really being kind of run by a multidisciplinary team involving cardiovascular surgery, cardiology, and vascular surgery. So we'll go over a little bit of the basics of DVT-PE. It's a lot to cover in 10 minutes, but we'll go over with a little bit more emphasis on treatment and such. So as you're all aware, venous thromboembolism is really a burgeoning epidemic where more and more patients are having DVTs and PEs, and almost if you look at the incidence of first-time thromboembolic event, it's almost 1 in 1,000 person years, and 1 in 3 patients present as PE and 2 in 3 patients present as DVT. And most PEs are always in association with a previous DVT. And as you can see in the last line, within 1 month of diagnosis, the mortality rate is really high for patients with DVT and PE. So essentially, it's a harbinger of badness, and usually it's due to the company it keeps. So as we can go through some of the risk factors for thromboembolism, again, major anything which leads the patient to be bed-bound in terms of whether they have had fractures or major orthopedic procedures or major neurological trauma leading to increased risk for thromboembolism. And as you can see in the intermediate risk factors, malignancies is a big contributor as it increases the thromboembolic risk due to hypercoagulable state. And same with a lot of end organ dysfunction, including chronic heart and respiratory failure. So, this is something that we all know in terms of how patients present, with redness, swelling, and pain. So I'm going to skip over this slide. And in terms of the criteria, a lot of things, this has really not changed for almost 15 years, where the Wells criteria has really been the clinical gold standard to risk stratify patients into low, intermediate, and high risk in terms of clinical pretest probabilities. So again, active cancer, paralysis, recently being bedridden, calf swelling, and pitting edema. So all of these are go into a risk scoring system, and we can come up with low, intermediate, or high risk for DVT. And based on that, either you can go through a clinical biomarker, which is D-dimer, or straight away go to venous duplex ultrasound to diagnose DVT. And now switching gears to pulmonary embolism. Again, this is, as we are all aware, patients come in with dyspnea, pleuritic chest pain, and there was a recent publication where a majority of patients who come in with syncope, almost 40% of them had an undiagnosed PE. So that's something that you all need to keep in consideration when you get consulted for syncope as as cardiologists. So the big thing to know is if you're suspecting PE and the patient is in shock or hypotension, then you really have very little time to act. So you have to really determine if these patients are high risk or not high risk, and then go from there. So this is just a CT angiogram for acute PE, and as you can see here, this the main pulmonary artery is even before the bifurcation is occluded. And again, so how do you clinically risk stratify patients? This is much shorter than the DVT Wells criteria. Again, if you have a previous history of DVT, or if you have any signs of right heart failure, which can manifest as heart rate greater than 100, and hemoptysis or a history of cancer or recent surgery, then you can come up with a clinical pretest probability, and anything greater than 6 you really have to worry about. So again, the same thing here. You either can go through biomarker-driven algorithm if your pretest probability is low, but if your pretest probability is high, then you have to go to a definitive diagnostic test, which is oftentimes these days in most hospitals a CTP protocol. So again, if you don't have shock or hypotension, then you have time to go to a CT angiography and then risk stratify patients. But if you have shock or hypotension, you need to really, if you can get a CT in the ER, then that would be ideal. But if not, you need to do a bedside ultrasound to see if the patient has RV strain or not, because you need to make a decision in terms of thrombolytics sooner than later. So there is a lot of controversy in the nomenclature of massive versus submassive PE. I think everybody is in agreement with how to define massive PE, whether anatomic or more physiologic, where it's associated. It's a big PE which is really in one of the proximal branches of the pulmonary artery associated with profound hypotension and bradycardia. But when it comes to the submassive PE, that's where there is a lot of controversy in terms of how to define it. We will go over that in the next couple of slides. Again, the cornerstone of treatment of PEs have been thrombolytics. Now, I think there is really no controversy in treating patients with massive PE with thrombolytics, because one thing we know that it's been shown to decrease the development of pulmonary hypertension, decrease death and hemodynamic compromise at 7 days, and decreased recurrence of PE. This is in patients with massive PE. However, there are disadvantages of thrombolytics, which leads to intracranial hemorrhage, especially in patients over the age of 75. And there is other major bleeding risk. This was in the PLETHO trial, which was a trial of using thrombolytics in PE. There was almost a 6% risk of other bleeding episodes. So in terms of, again, evidence for thrombolytics, the number needed to treat is 59 for all-cause mortality benefit in patients with massive PE. Again, now I think the area is sort of developing into whether we should use lesser and lesser doses of thrombolytics. And there was another trial from the Phoenix group, the MOPET trial, which looked at half-dose thrombolytics. And actually, it was quite beneficial, but it reduced the bleeding risk significantly in patients with massive PE. I just wanted to touch briefly about what anticoagulation to use as short-term or long-term in these patients. I think the NOACs, so the newer anticoagulant agents, have been clearly shown to be superior to warfarin. So the way to think about it is, it's very clear when you have a patient with PE. If you think that it's an unprovoked PE, then these patients should be really on lifelong anticoagulation until unless there is a contraindication for anticoagulation. If patients have provoked PE, then you can really make a determination based on their other risk factors and RV dysfunction to decide how long to treat. But usually 3 to 6 months will suffice in patients with provoked PE. Now, I just wanted to touch upon briefly about intermediate risk PE. I don't have slides on that, but these are patients who do not have hypotension when you see them. So in these patients, if you have evidence of RV dysfunction, or if you have an evidence of any biomarker leak, which means positive troponin or positive BNP, you can make a case for thrombolytics. Now, again, you have to balance the risk of bleeding and the benefit. Now, there was a recent analysis from the Pietro trial, which was an intermediate risk PE trial looking at thrombolytics. And what they found was even though there was benefit within the first 7 to 30 days, long-term benefit was not really there. There was no benefit at 1 year. And a lot of these patients who got thrombolytics were still very symptomatic in terms of their dyspnea and exertion. So there is a lot of debate in the field in terms of whether, in these patients who have intermediate risk PEs, whether you should be giving at least systemic thrombolysis. So that's where some of these other catheters come in, and I guess this is probably the older slides, I think, but the newer slides had, but there are certain catheters, and I just wanted to talk about one, which is the ecosystem. So it's a catheter which sits in your pulmonary artery. You can put it through the IJ, and it delivers ultrasound pulses. And what you can do is, since the catheter sits in the PE, in the pulmonary artery, you can deliver lower doses of thrombolytics. And compared to, again, was a really small trial of 140 patients, compared to, say, the MOPET trial, where you could do half-dose thrombolytics, the incidence of intracranial bleeds was really, really low. So that is where I think that frontier of treating PEs is exciting, and that's where the field is going to, where you're using lower dose thrombolytics with more catheter-directed thrombolytics to decrease the risk of ICH. But again, the long-term consequences of this are unknown and remains to be seen. This is a quick thing about embolectomy. Again, in patients with massive PE with shock, either they need to go for surgical embolectomy, and I see Dr. McGilvery there at the back. I think we just got a consult overnight for a submassive PE. So I think, at least for us, it's almost weekly, if not a couple of times a week. We see a lot of these patients with submassive and massive PE. Again, if you think the patient has a massive PE, you need to be calling your cardiac surgeon so that they can take them to the OR sooner, because that really can be life-saving in the setting of ongoing hypotension. I think that's it. Thank you very much.